Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the NICE guideline on primary hyperparathyroidism, or NG132, focusing on what is relevant to primary care only. Make sure to stay for the entirety of the episode, because at the end I will also touch on secondary and tertiary hyperparathyroidism. Right, let's jump into it. So what features could indicate primary hyperparathyroidism? Well, experience suggests that hypercalcemia in primary hyperparathyroidism is commonly associated with symptoms such as thirst, frequent or excessive urination, and constipation, and with conditions such as osteoporosis, fragility fractures, and renal stones. So these are the prime clues to look for. However, sometimes there are also chronic non-specific symptoms, including fatigue, anxiety and depression, confusion, irritability, and digestive problems. And of course, primary hyperparathyroidism can also be asymptomatic, showing simply as hypercalcemia. Hypercalcemia is defined as a corrected calcium of 2.6 or more. What diagnostic testing should we do in primary care? Of course, the main initial test is the albumin-adjusted serum calcium, which from now on, and for simplicity, I will refer to as just corrected calcium. We should not rely on ionized calcium. This is because calcium that is bound to albumin is not active and does not have clinical effects, so adjusting for albumin is a better measurement. Furthermore, ionized calcium is not subject to the same stringency of laboratory testing, and the sample has to be handled very quickly, making it unreliable. And when should we check corrected calcium? We will definitely check it if we suspect primary hyperparathyroidism because of, as we have just said, symptoms of hypercalcemia, primarily thirst, frequent or excessive urination, or constipation. But we will also consider it for those with chronic non-specific symptoms. Or if there are conditions like osteoporosis, a previous fragility fracture, or a renal stone. Then we should repeat the corrected calcium if the level is either high, that is 2.6 or above, or if it is 2.5 or above and features of primary hyperparathyroidism are present. And you may ask yourselves, should we be checking parathyroid hormone or PTH with this second blood test? Well, NICE says not yet. This is because calcium levels can vary with changes in blood pH or albumin, and the cost of the test is low, so it should be checked at least twice before moving on to more expensive tests like PTH. So then we will check PTH if the corrected calcium level continues to be either high, that is 2.6 or above, on at least 2 separate occasions, or if it is 2.5 or above on at least 2 separate occasions and primary hyperparathyroidism is suspected. But you may be thinking a corrected calcium of 2.5 is in the normal range. Should we even be thinking of primary hyperparathyroidism in these cases? And NICE explains that although most people with primary hyperparathyroidism have hypercalcemia, there is a smaller number of people that develop what is called normocalcemic primary hyperparathyroidism, which often goes unrecognized. So this is the reason for this lower calcium threshold. When measuring PTH, we will check the corrected calcium again at the same time. To check PTH, we can use a random sample at any time of the day because although there is a marginal diurnal difference, it is not enough to need adjusting for. Once checked, we should not routinely repeat the PTH in primary care, so we will rely on this single test. Once we have the results, we will conclude that primary hyperparathyroidism is unlikely if the PTH is below the midpoint of the reference range and the corrected calcium is below 2.6. However, we will refer to a specialist if the PTH is either below the midpoint of the reference range but with a concurrent corrected calcium of 2.6 or more, or if PTH is above the midpoint of the reference range and primary hyperparathyroidism is suspected. Considering that we should not be checking PTH unless we suspect hyperparathyroidism, this means that we may have to refer patients even if the PTH level is within the normal range, as long as it is above the midpoint of the reference range. Do we need to worry about low PTH levels? Well, NICE says that we should look for alternative diagnoses, including malignancy, if the PTH is below the lower limit of normal. Why is this? A low PTH or hypoparathyroidism can have several causes, including autoimmune diseases, genetic disorders, and low magnesium, but also malignancy. Certain cancers, particularly those that metastasize to the bones, can disrupt the normal function of the parathyroid glands. Additionally, some cancers can produce substances that mimic PTH, causing hypercalcemia of malignancy, which can suppress the normal parathyroid function. Now, moving on, although NICE recommends the following tests in secondary care, some of them can be done in primary care, so we can use our clinical judgment in this respect. These tests are vitamin D. This is because vitamin D deficiency can lead to a rise in PTH level and exacerbate bone disease, and therefore assessing and correcting vitamin D is important. However, NICE also considers that waiting for vitamin D to be checked and corrected if necessary could delay the diagnosis of primary hyperparathyroidism. So, in summary, although we could indeed check it, we should not delay referral because of it. The other tests that we can consider are less common in primary care. They are tests to check urine calcium excretion, for example, with a 24-hour urinary calcium excretion. They are used to exclude familial hypocalciuric hypercalcemia, so perhaps they're really best left for secondary care. Now, secondary care will decide which cases of primary hyperparathyroidism need referral for surgery and which follow-up is needed after it, depending on whether the surgery is deemed to have been successful or not. However, we need to be aware that patients who haven't had successful surgery should be monitored by checking corrected calcium and renal function at least once a year, a renal ultrasound scan at diagnosis and if a renal stone is suspected, and a DEXA scan at diagnosis and then every 2 to 3 years until the hyperparathyroidism has been corrected. Whilst the bisphosphonate can be considered for those with an increased fracture risk, it should not be used just to treat the hypercalcemia in primary hyperparathyroidism. And of course, primary hyperparathyroidism in pregnancy should be managed in secondary care, being aware that these patients are at increased risk of hypertensive disease in pregnancy. Now, as promised, I am going to tell you a little about secondary and tertiary hyperparathyroidism. But before, let's go through some definitions. Primary hyperparathyroidism is when the parathyroid glands produce excessive amounts of PTH without any external trigger. That is, it is an intrinsic problem within the parathyroid glands, and the most common cause is a benign tumor or adenoma. Secondary hyperparathyroidism is when the parathyroid glands overproduce PTH as a compensatory response to low calcium, and it is the body's attempt to normalize the levels. Possible causes are chronic kidney disease and vitamin D deficiency. And finally, tertiary hyperparathyroidism is when hyperplastic parathyroid glands overproduce PTH autonomously, that is, not responding to normal regulatory feedback. This is generally seen after prolonged secondary hyperparathyroidism in patients with CKD. And let's quickly look at the pathophysiology of tertiary hyperparathyroidism. In CKD, the kidneys lose their ability to excrete phosphate, leading to hyperphosphatemia. In CKD, the kidneys also produce less active vitamin D, resulting in decreased calcium absorption and hypocalcemia. Both hypocalcemia and hyperphosphatemia stimulate the parathyroid glands to produce more PTH to maintain calcium levels. This is the secondary hyperparathyroidism stage. However, over time, the continuous stimulation of the parathyroid glands leads to glandular hyperplasia, and as it progresses, the parathyroid glands become less responsive to normal feedback mechanisms. So, in some patients, particularly in those after prolonged and severe secondary hyperparathyroidism, the parathyroid glands can become autonomous, meaning that they secrete PTH independently of blood calcium levels. At this stage, even when the initial cause of secondary hyperparathyroidism is corrected, for example after a kidney transplant, the overactive parathyroid glands continue to produce excessive PTH, which lead to hypercalcemia. This is when we talk about tertiary hyperparathyroidism. So that is it, a quick review of the different types of hyperparathyroidism. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching, and goodbye.